We would like to welcome you to the presentation of Managing Physician Group Practices. We are Group 4, consisted of Sean Fulton, Kim Stanley, Sabrina Wall, and Jennifer York. Currently, most physicians practice in a group setting. The composition of this trend has been one of change and growth. We would like to give a quick historical nod to the Doctors Mayo, a group practice that began in 1883 with a team of a father, two sons, and later a Dr. Stichenfield. Shortly after Dr. Stichenfield accepted the position with the Doctors Mayo, the founder, Dr. William Mayo Sr., retired. Next slide. Practice continued to grow, adding more doctors and adding administration to help run the business side of things. In 1908, a man by the name of Harry J. Harwick started his 40-plus tenure working for the Mayo private group practice. As a protege of Dr. Will Mayo Jr., he has said in the past that Dr. Will found administration more exhausting than medicine and surgery. Harwick is known as one of the first ever practice administrators, a key figure in developing the concept of lay administration, and is distinguished as a founder of MGMA. Next slide. The acronym MGMA stands for Medical Group Management Association. It is known as the premier association for professionals who lead medical practice. It is both a professional and advocacy organization. The birth of MGMA was in 1926 when the first of what became an annual conference of clinical managers was held. This same conference is what is now known as the MGMA Annual Conference. The purpose of the conference is to discuss current healthcare issues. MGMA has defined their mission as to elevate the performance of medical practice leaders and their organizations by connecting members, building partnerships, setting the standards for certification, advocating for physician practice, and providing innovative solutions. Next slide. MGMA is headquartered in Englewood, Colorado, and provides several services and education to its paid members, including political advocacy for medical practice management, networking, and professional resources. They have surveys, e-reports, books, magazines, conferences, online classes, webinars, and more. Your membership in MGMA allows you to have a wealth of knowledge and current benchmark data at your fingertips. Next slide. MGMA also has a resource called the Body of Knowledge for Medical Practice Management. This literature is known as the authoritative guide to managing a successful medical group practice and gives an abundance of knowledge for different skill sets needed for medical group managers. It was developed by the American College of Medical Practice Executives, also known as ACMPE. Next slide. ACMPE is a sister organization to MGMA and recognized as the standard setting and certification body of the Medical Group Management Association. MGMA also offers courses for those who wish to be certified through ACMPE. It is important to note that ACMPE is a professional organization and does not participate in advocacy. It is the credentialing body for healthcare managers. Next slide. The role of MGMA is to help their members navigate the healthcare system changes that are intended to deliver more affordable, higher quality patient care. With membership of more than 40,000 medical practice administrators, executives, and leaders, MGMA represents more than 12,500 organizations of all sizes, types, structures, and specialties that deliver almost half of the healthcare in the United States. MGMA also has an affiliate agreement with all 50 states in the U.S. MGMA state affiliates provide state-level networking, education, and volunteer opportunities. Being a member of your state affiliate doesn't make you a member of the National Association, and being a member of the National Association does not make you a member of your state affiliate. You must be a member of both to receive all the benefits available to you. Currently, MGMA offers different membership levels. The current annual price to join, if you are a medical practice professional is $399. There is a membership option for students. The annual price is $35, and you must be a full-time student. They also offer a 30-day free trial with limited access to their resources. Every paid membership receives access to the certification programs offered through ACMPE. Next slide.
Working for and with physicians can bring its own unique set of challenges. Over the next few slides, we will outline the biggest challenges a healthcare administrator may face while working with physicians. They include strained physician-administrator relationships, cultural differences, and trust. Next slide. Strained physician-administrator relationships. In a recent study conducted by the Mayo Clinic, 54% of physicians surveyed reported a loss of enthusiasm for work, feelings of cynicism, and a low sense of personal accomplishment. That number has increased by 10% over the last 3 years. What's to blame for this dissatisfaction? The healthcare industry is rapidly changing, and with these new changes come a new set of expectations and requirements. A new common sentiment of physicians is, why are there so many administrators involved in the delivery of care now when there were so few in the early days of my career? Physicians make money by seeing patients, and sometimes it feels that the administrator interferes with their ability to do that. In turn, healthcare administrators are more often responsible for making sure that these new expectations and requirements are met, causing them to be more involved in the physician's care of patients. The relationship between those who deliver healthcare and those who administrate it is growing more and more tense. Physicians want to be able to simply take care of their patients and would prefer that administrators steer clear and let them do that. Miscommunication and a predisposition for a physician's distrust are some of the major reasons why trust is its very own challenge. Next slide. Trust. J.S. Buczak defines the challenge with trust very clearly by saying, trust is the foundation of all meaningful and sustainable relationships. Sadly, almost everyone would agree that physicians and hospital administrators generally do not trust each other. It is my contention that miscommunication is the reason for this lack of trust. Misperception and assumptive biases lead to misunderstandings that are then labeled as reasons why the other is not trustworthy. To begin with, physicians are highly competitive individuals and have a predisposition not to trust. Seeing the world in terms of win-lose causes the competitive person to be suspicious of others who are seen as competitors in a zero-sum game. Most physicians are not trained on the financing or organizing of healthcare. They don't understand the red tape and paperwork and the hoops that must be jumped through in order to remain compliant in the industry. Nowhere in their pre-medical education, medical school, residency, or fellowship do most physicians get a comprehensive education on healthcare policy, administration, finance, or organizational behavior. It's no wonder that there is a world of suspicion between those of us involved in administrating and financing care and those involved in actually delivering it. When you are working with different understandings of how the world is structured and why, mistrust, misunderstanding, and miscommunication are soon to follow. Each party defines success in its own way, and when the relationship fails to meet its unique expectations, it concludes that the other parties are not trustworthy. Buczak explains that he believes trust develops in proportion to the frequency of meaningful interactions. All meaningful change occurs through conversation. Therefore, he believes these challenges can be easily overcome through honest, meaningful conversations and interactions. Setting clear expectations and boundaries will help everyone to get on the same page and move forward with trust. Next slide. Cultural differences. The culture of an office is defined as an organization's beliefs, values, traditions, attitudes, behaviors, and interactions. These combine to create the organization's unique personality and culture. The challenge of cultural differences in the office lays in a paradox between calls for common set of values and the need to recognize that doctors and managers do and should think differently. What is important to one group may not be equally important to another. As you can see in this chart, some of the values overlap, but how and when they are achieved may be different depending on which group you ask. According to J.S. Bujak, whereas physicians comprise an expert culture, the HCO is predominantly a collective or affiliative culture. In collective cultures, process is more important than outcome. Respecting emotions is paramount, and teamwork is the metaphorical equivalent of volleyball or football, a reflection on role interdependency. Collectives want to be certain that everyone is heard and that no one's feelings are injured, and they are primarily motivated by relationships and recognition. Experts, on the other hand, want to make a decision and move on, and are primarily motivated by accomplishment and power. This yin and yang of cultures is responsible for considerable misunderstanding between doctors and others in the healthcare community. Although Bujak points out the challenges with difference in values, others speculate that this tension provides an appropriate and needed balance. Physicians' primary focus is on the patient and their outcomes, as it should be. Managers and administrators tend to focus on patient outcomes and experiences as well, but more as part of a whole picture and part of finite resources. Patients are best served when there is an appropriate tension and balance between these two cultures. Next slide. Healthcare administrators and managers face their own set of challenges not directly related to working with physicians. These challenges include physician recruitment, financial performance, managing group culture, and documentation and coding accuracy. Next slide. Physician recruitment. As more Americans gain access to health insurance, the need to recruit and retain even more physicians is greater than ever, and it's likely that this won't change anytime soon. Here are some reasons physician recruitment is a challenge for medical group practice managers. First, lack of supply. As stated before, health insurance is becoming more and more accessible, and individuals who haven't been able to see their doctor in years are now able to be seen for the first time in a long time. They are even able to afford appointments with specialists. By the year 2020, it is expected that there will be a shortage of at least 90,000 physicians. And in the US, they were not doing anything to keep up with this increased demand. The amount of residency positions are remaining the same and not expected to increase anytime soon. Second, oversaturation. As medical groups begin acquiring existing physician practices and opening new ones, the market for recruiting physicians became extremely competitive. As these practices grow and acquire more patients, the job market for physicians is oversaturated. Physicians looking for opportunities in specific communities will often find dozens of opportunities with multiple competitors. This leaves medical group practices battling for a very limited pool of candidates. Location. Many large metro areas along the coast have less trouble attracting candidates based on location alone. Meanwhile, recruiters in rural communities and areas with few cultural activities can take well over a year to fill certain searches. This divide is especially true of younger physicians, many of whom became accustomed to having easy access to culture, activities, and recreational options during their medical education and residencies. Because of this, many physicians have begun to prioritize the quality of life and generally shy away from the less populated areas. Next, physician retirement. Many physicians of the baby boom era are coming to an age of retirement, causing medical groups to struggle to maintain their top talent. In addition to these retirements, some seasoned physicians who are reluctant to embrace changes made through the Affordable Care Act are choosing to retire rather than comply, taking decades of experience with them when they go. Rising salaries. Physician salaries in many different specialties have increased 13% over the last year and are expected to continue to rise. The cost of recruiting and hiring new physicians is rapidly and dramatically increasing. This is a challenge to many healthcare organizations operating on strict budgets, making it difficult or even impossible for them to offer competitive salaries that will attract candidates. Next slide. Managing financial performance. Medical group practices are having increasingly difficult time being financially successful for several reasons. Government and health insurance reimbursement has remained the same for several years with no increase, whereas the cost of operating the practice has consistently increased. Costs are going up, but reimbursement is remaining the same. The healthcare industry is changing quickly, and practicing medicine is becoming more and more complex. This means that the cost of providing healthcare is driving up operating costs. Medical group practices are being required more and more to measure and quantify quality and other parameters. These are expectations that have not been present in years past, which again is driving up operating costs. Documentation requirements have also grown while the difficulty of documentation has increased. Many groups are seeing compensation reductions based on inadequately documented and diagnosed care. Next slide. Managing group culture. If practices want to achieve high performance standards, it is necessary that physicians change their habits and begin to participate in new ways of providing and managing care. It's unrealistic for a group to expect high performance unless their physicians will join in the leadership and make necessary transformations. Frequent and meaningful communication is the most effective way to build trust. Physicians should have a direct communication link to the administrator or to a designated representative who has the authority to make decisions. Administrators should work closely with physicians and value their input and suggestions rather than viewing them as just another employee they manage. Next slide. Documentation and coding. New guidelines for coding and documentation can be complex and confusing. Typically, physicians will have very little training in this area, and the way a physician will code the procedures they performed can vary greatly from one provider to the next. When physicians are uncomfortable or uneducated in coding, they have a tendency to undercode their work. This can lead to a tremendous loss of revenue within a practice. If a physician with an average of 3,500 patient visits a year undercodes just 10% of his or her encounters, it can result in a $10,000 per year loss in revenue. In addition to the loss of revenue, poor documentation increases medical legal risk and the risk of an audit.
There are many legal and regulatory issues to consider while managing a medical group practice. We have covered many of these in this class and in others, so I'll just do a brief overview of each one of them. Next slide. Licensing. In order for a physician to practice, they need to be licensed by the state. Most states have renewal every 2 years, and in addition to paying a fee, continuing medical education needs to be documented and sent in. To operate any business, you will need a business license from the city your business is in. If you sell any products in the office, in many states, you will also need a sales tax license through the city or county or possibly both. Another important license is through the DEA, which is the Drug Enforcement Administration. This allows the physicians in your group to prescribe medicines. This license needs to be renewed every 3 years. Physicians are extremely busy, and they often expect practice managers to make sure their licenses are up to date. Human resources primarily deals with employment law. Being a manager, you will supervise employees. Many states have different employment laws, but there are also federal employment laws, so it is important to be familiar with those laws that apply to your practice. As a manager, you will be responsible for risk management. Liability is a major factor in the healthcare industry. So physician and facilities use risk management to minimize their liability. Risk management involves identifying problem practices or behaviors and then eliminating or controlling them. A few risk management activities that can help lower legal risk in the human resources area are providing written job descriptions for employees and providing office procedural manuals in employee handbooks that can help avoid misunderstanding. In addition, within the practice, having proper training and procedures for medical record charting, patient scheduling, writing prescription, and communications with patients is important. With compliance programs, healthcare organizations must be compliant with changing healthcare trends, guidelines, laws, and government regulations to minimize the risk. So the area of compliance generally applies to human resources, risk management, and billing practices. OSHA, which is also called the Occupational Safety and Health Administration. Its function is to assure safe and healthful working conditions by enforcing standards. All employers must know those standards and apply them to their business. As a manager, you would be expected to know those standards as well. One regulation that may apply to medical practice management is the Occupational Exposure to Blood-Borne Pathogen Standard, which is a regulation from 1991. Clinical Laboratory Improvement Act, which is also called the CLIA, regulates laboratory testing and requires clinical laboratories to be certified by their state as well as the Center for Medicare and Medicaid Services before they can accept human samples for diagnostic testing. This probably would apply more to larger groups that are hospital-based or vertically integrated medical center that do offer laboratory services. The Health Insurance Portability and Accountability Act, which is also called HIPAA, is a federal law passed in 1996 to protect privacy and other healthcare rights for patients. The act helped workers keep continuous health insurance coverage for themselves and their dependents when they change jobs, and also protects confidential medical information from unauthorized disclosure or use. It was also intended to help curb the rising cost of healthcare fraud and abuse. Stark Law and anti-kickback laws are laws designed against self-referral. Under the Stark Law, physicians or members of their immediate families who have financial relationships with healthcare entities may not refer patients to those entities if the federal government is responsible for payment. It is important to note that not having intent does not make you not responsible for following that law. So if you're not aware of what you're doing, the facility that you're referring the patients to, you can still be charged and prosecuted for violating the Stark Law and possibly pay a fine or prison time. The anti-kickback statute states, anyone who knowingly and willfully receives or pays anything of value to influence the referral of federal healthcare program businesses can be held accountable for a felony. Recovery Audit Contractors is a program created through Medicare and the Modernization Act of 2003 to identify and to recover improper Medicare payments paid to healthcare providers under fee-for-service Medicare plans. So as a manager, you would need to familiarize yourself with the billing practices and oversee the practice to make sure the billing practices fall within the federal law guidelines and are not being overcharged, because that, again, could land your practice in serious trouble with charges and fines having to be paid. The Physician Payment Sunshine Act requires medical product manufacturers to disclose the Centers for Medicare and Medicaid Services any payments of other transfers of value made to physicians or teaching hospitals. Antitrust laws are established and designed to protect trade and commerce from abusive practices to allow for fair competition. Violations would include price fixing restraints, price discrimination, and monopolization. The Centers for Disease Control, which is the CDC, they also set standards and guidelines for collecting and handling specimens. In addition, they also track and study infections rates, so that may apply to a practice that you manage as well. And lastly, the American with Disability Act prohibits discrimination against individuals with disabilities in all areas of public life, including jobs in public and private places that are open to the general public. Next slide.
Next, we're going to discuss the role of entrepreneurship in the medical arena. Google defines entrepreneurship as the activity of setting up a business or businesses taking on financial risks in the hope of profit. As a physician group manager, your job is to run a profitable business while maintaining the best care that can be provided. Why be an entrepreneur in healthcare? MGMA has reported in 2014 that medical groups are experiencing rising costs associated with the business office staff. The cost in that report was just over $52,000 per full-time equivalent physician. This cost continues to rise with inflation in the economy and increased operation costs. This is basically due to the rising needs of having more staff at medical group practices. So because of that, each full-time equivalent physician partner who is in ownership or responsible financially for that practice is incurring increased costs annually. Competition. shows that there are approximately 230,187 physician practices in the United States. 16.5% of them are one physician only practices, but the remaining 83.5% have at least two or more physicians operating in that practice. These numbers are continuing to rise as the healthcare marketplace continues to boom. Compensation. Limited insurance company acceptance, as well as the emergence of managed care through HMOs and PPOs. Not every insurance is accepted by every medical group. Along with the HMOs and PPOs negotiating group contracts for only specific providers or accepting providers only within their network, it is possible that some patients will not be able to come visit your practice, and that will limit the pool. Volatile market. Markets are ever-changing, with groups in metropolitan areas being concentrated near medical campuses and physicians constantly moving due to recruitment and integration with other medical groups. As physicians continue to undergo change in their management, they will take up contracts and go into relationships with other medical groups as a way to be able to manage their operations more effectively. Results from entrepreneurship and medical groups. With all the previous information stated, the results are smart financial management leads to increased net profit. These profits can be reinvested into the group. MGMA reports exploring new technologies and increasing efficiencies is one of the 5 key successful medical group practices. Successful marketing and networking leads to an increase in patients, and enhancing the patient experience leads to further growth. By applying these principles in your medical group practice management, you'll be able to grow the patient pool, increase profits, and reinvest into the increasing costs of the industry. Continued from the previous slide, we have a quote from Todd Evanson, who is the MGMA VP of Data Solutions and Consulting Services. He says, quote, "Medical practices introduce data as often as possible to help make and support business decisions. To run an efficient and effective business that meets patients' needs, practices need to capture and understand many metrics and use the information in meaningful ways. Using data and indicators, such as those found in MGMA benchmarking reports, puts a practice on the fast track to success." Basically, what Todd is trying to say is that by choosing to operate your medical practice as your business, you will be able to save money and be more effective in delivering care. And if you do those two things, then you will be successful so long as you can continue that throughout the future. By applying all those principles, you'll be able to have smart financial practices and provide quality care. This will ensure that you have a successful business. By running a successful business and having happy patients, you will be able to pay your staff. And by paying your staff makes them happy, that means you are fulfilled in your duties as a medical group manager. More that were not listed in this slide, but basically your goal as a medical group manager is to employ the right people who provide quality care while making the business profitable. The entrepreneur spirit will increase your ability to be successful in your efforts. Treating the medical group as if you own it will drive revenues, lead to happy owners, and open doors for you to move on to greater opportunities.
What can you do to position yourself to become a medical group practice manager? Become a jack of all trades. Next slide. The Medical Group Management Association utilizes a body of knowledge. The body of knowledge for the medical practice management is so essential to success. It serves as a repository of industry knowledge, a guide to practice management and assessment of competency, and a learning tool. A brief overview of the categories included in this body of knowledge are operations management, which is managing daily operations, financial management, which is developing and maintaining financial systems to ensure a profitable practice, human resource management, which is effective staffing and compliance with employment law, risk and compliance management, which provides an overall safe environment, preventing or minimizing adverse effects, patient-centered care, which is ensuring patients receive the best possible care, and organizational governance, developing long-term strategies and strategic direction of the organization. Next slide. This is just a quick graph, pie chart, and you will find this information in the slide PowerPoint presentation in the lesson as well, that just basically breaks down the different categories of the body of knowledge. And as you can see, what I noticed about this is that operation management and financial management cover over 50% of this body of knowledge. So increasing your knowledge and experience in these and the other categories as well can help make you more attractive to a potential employer. Next slide. In addition to the body of knowledge, I looked at what other practices we're looking at in managers, and on the slide are just a few of the things that I regularly came across, a few characteristics that I regularly came across in several different job postings. Excellent communication, attention to detail, business sense, leadership capabilities, RN or clinical experience, capable of motivating and delegating, compassion for people and patients, sense of humor, skilled negotiator, good personality, critical thinking skills, bookkeeping experience, desire to continuously learn, and works well with other people. The last two I thought were pretty important because with medicine, there's one guarantee, and that is that everything is always changing in medicine, in healthcare. And so you constantly need to be learning and staying up to date with everything that is changing. And the works well with other people is an important aspect for a manager. And that's just based on my own experience. Working in my husband's office, after I had kids, he brought in a manager to kind of help oversee everything when I was taking care of young kids and couldn't be there every day. And the manager did not work well with other people, and it created such a high turnover rate that it ended up costing our practice money because employees were quitting at a rapid pace and we'd have to rehire and retrain. And so as I thought about a practice manager, I thought that that was a very important characteristic. Next slide. So other things that you can do to position yourself as a medical group practice manager are to enroll in an undergraduate or graduate degree program, which we all are in our degree programs, but you can also take that a step further to get a graduate degree. It's an MBA or an MHA. I'm looking for leadership opportunities to strengthen your leadership experience. And those leadership opportunities can be volunteer opportunities. They don't have to be in a management position at work. Begin working in a medical facility and come up through the ranks. I think that that's a very important one because you get to know all aspects of the workings of the medical office, so you can relate to the other employees and understand what their job functions are and also fill in when needed. Gain management experience. So gaining management experience can come from different areas of life, by even assisting managers in your current job, or managing a family, or managing your family finances, or like having a church calling and managing your time. So that kind of management, I think, is valuable experience that can help assist you in a practice manager position. Look for continuing education opportunities. And it was pointed out in one of the other slides that the continuing education opportunities are offered through the Medical Group Management Association. And they have an annual conference, and they also have webinars. So if you did join that association, you could have access to those great continuing education opportunities. But there's also ones to be had too. If you work in the medical field, insurance companies are regularly hosting continuing education. Malpractice carriers are offer continuing education and risk management. So there's lots of opportunities if you just look for them. Joining professional networks such as the Medical Group Medical Association can help give you resources and help increase your knowledge base. seeking out mentors, and mentors can be people that you work with. They can be people that you know, really anybody found in any aspect of life, in personal or professional life. Seeking out opportunities, and that can come from something simple like volunteering in a hospital or joining a local networking group. It's amazing the kinds of people from different backgrounds that you do meet if you look for those opportunities, and you can have tremendous success by getting your foot through the door with people that you know. And last one is understand and embrace technology. And I thought that this was a really important one, especially with the transition of electronic medical records. A lot of physicians that have been charting and doing medical records for years have had tremendous difficulty transferring to electronic medical records. And I just experienced that myself earlier this year. And it was quite a learning experience, but I would highly recommend that understanding and embracing that technology would really give you an added benefit to managing a physician group practice. Next slide.
We were asked to define the Medicare substantial growth rate formula and relate it to the challenge of managing medical groups. The sustainable growth rate formula, adopted by Congress in the late 1990s, was a Medicare physician payment rate plan. It was developed to help control federal spending by Medicare physicians and was set to a formula based upon the United States economy's annual rate of growth. For a few years, the plan worked. Medicare expenditures at that time were not excessive. Through the sustainable growth rate formula, doctors saw some modest pay increases for their work as well. However, in 2002, the Medicare expenditures exceeded the government set targets. The consequence to that was an average of 4.8% pay decrease to physicians. Doctors across the nation were furious. Next slide. From 2002 on, the expenditures continued to exceed the targets each year with a wider gap. While physicians and Congress could agree that the sustainable growth rate formula was fundamentally flawed, the idea of scrapping the law altogether was daunting to Congress. They felt that it would be too costly to terminate the law. However, in an effort to fix what they all knew was broken, Congress continued to provide expensive doc fix patches to avoid the reductions. During the years 2003 through 2014, there were 16 laws that had been passed to override the sustainable growth rate reductions. The sustainable growth rate formula was finally repealed in 2015. It was replaced with the Medicare Access and CHIP Reauthorization Act of 2015. Next slide. In our current situation in 2017, we are bouncing between the ideas of will they or won't they repeal the Patient Protection and Affordable Care Act, also known as Obamacare. The uncertainty of how medical practices will be reimbursed has become more of a normal situation than anyone in medicine cares for it to be. Susan L. Turney, who is a medical doctor and CEO of Marshfield Clinic Health System, and former CEO of MGMA, has said, quote, physician practices are doing more and more to innovate and respond to a rapidly changing environment to meet the needs of their patients, but with fewer resources. They are working diligently to manage rising operation costs and prepare for potential cuts to reimbursement rates, and are also navigating a number of other transformative federal policies. It is understandable that financial management issues rank among the most pressing concerns for our members, end quote. Financial uncertainty due to political climate is challenging for the managers of medical group practices. It seems to especially take a toll on the morale of the physicians practicing, not knowing if they will be fairly reimbursed for the quality of care they are performing and would like to continue to perform. Next slide.
The MGMA position on the Patient Protection and Affordable Care Act, specifically the House of Representatives Bill 3590 and 4872. On March 20th, 2010, the MGMA president and CEO, William F. Jesse, wrote a letter addressed to House Speaker Nancy Pelosi and House Minority Leader John Boehner, posed regarding the Patient Protection and Affordable Care Act, as well as the Healthcare and Education Affordability Reconciliation Act of 2010. The letter discloses MGMA's concerns and disagreements, along with encouraging leaders to go into certain directions with the bill. The key concerns were sustainable growth rate Medicare formula. Mentioned in previous slides, MGMA's specific concern with this was that claims were cut 21% to physician payment under Medicare. The Independent Payment Advisory Board. MGMA was concerned that an Independent Payment Advisory Board will worsen practices' financial stability by decreasing Medicare reimbursement. So to summarize, those two are all about reimbursement. Imaging services. MGMA opposes the cuts that would limit imaging services since the reimbursement rate is too low to pay for the services. We see a trend in the industry where costs are increasing, but Medicare will not cover the full cost of imaging services, so a lot of physicians and imaging service centers will not accept the Medicare reimbursement unless there is provisions made to pay for the rest of the service. Tort litigation. Legislation does not reform tort litigation, even with $50 million of grants being awarded to the states to explore alternative resolution of medical liability claims. MGMA was mainly concerned that the House of Representatives and Congress was not going to address this issue and instead push it off on other legislative bodies where they will unfortunately debate over it, and then no full legal resolution will be put in place. New physician-owned hospitals were under fire. MGMA opposes the proposal to eliminate new physician-owned hospitals and advocates for them as they benefit the community, particularly in rural areas. Medicare fraud enforcement. Medicare fraud enforcement policies cast too wide of a net by modifying intent requirement for violations. This jeopardizes honest providers by further complicating the regulations and will lead to more accidental fraud cases. As we previously mentioned in the presentation, the changes in medical group management as well as all of healthcare have been constant over the last couple of years. And with those changes comes a new way of conducting Medicare business and reimbursement. A lot of providers make mistakes on those claims, even though they're not intending to, simply because they can't keep up with all of the changes. And finally, simplification. HIPAA and electronic transactions are limiting efficiency for medical providers. Standardized electronic patient cards also was missed in the legislation, which still causes unnecessary loss of time and resources. Basically, they want to eliminate redundancy to be able to increase efficiency throughout healthcare providers. The conclusion of the letter to the House of Representatives. There's a quote from William F. Jesse that pretty much sums up that point. He says, quote, MGMA appreciates your outreach and willingness to participate in constructive dialogue to improve the current health system. We remain ready to continue working with you and your staff as you consider issues affecting physician group practices. It was an opportunity to list all of the key concerns and complaints against the healthcare legislation in an effort to repair damaged relationships within Congress to regain support, and a chance to shed light on additional old issues that have been plaguing the system but have yet to be addressed.
As Jennifer discussed previously, the sustainable growth rate was repealed, but it was a method used by the Centers for Medicare and Medicaid Services in the United States to control spending by Medicare on physician services. The theory behind ending the SGR was the formula threatened clinicians participating in Medicare with potential payment cliffs for 13 years. And I do remember just before this law was appealed, for several years towards the end of the year, we had a standing rule that we would not schedule any new Medicare patients in January because we were waiting to see what Congress did. And every single year they did those fixes that Jennifer talked about and kicked the can down the road. And so just before MACRA was introduced, physicians were facing around a 25% decrease to their Medicare payments. And a lot of people don't understand is what happens with Medicare payments will follow with commercial insurance payments, because most commercial insurance contracts base their reimbursement rate off of current Medicare rates. And so that's what the big uproar was with those Medicare payments being cut. But the SGR was repealed and was replaced with MACRA, which is the Medicare Access and CHIP Reauthorization Act of 2015. And the passage and implementation of MACRA will fundamentally change the way the United States evaluates and pays for healthcare. Next slide. So on April 16, 2015, Barack Obama signed the Medicare Access and CHIP Reauthorization Act of 2015, also called MACRA. And again, this replaced the SGR. The system is more of a value-based versus volume-based system. So MACRA does many things, but most importantly, it establishes new ways to pay physicians for caring for Medicare beneficiaries. The law also includes new funding for technical assistance to providers, funding for measure development and testing, and it enables the new programs and requirements for data sharing, and establishes new federal advisory groups. It is estimated to cost the healthcare industry $1.3 billion. A Forbes report was also cited that the CMS actuarial score of HR2 projected that $387 billion would be reduced from Medicare's Part A, which is the hospital, unfunded liability, and $2.5 trillion would be reduced from Medicare Part B, which is doctor visits, unfunded liability. So that brings the reduction and the present value of Medicare's unfunded liabilities to nearly $3 trillion. So basically, Medicare is looking to save that amount of money, the $3 trillion in the healthcare industry. So even though the price tag to the health industry is 1.3, the savings will far surpass that. It's projected to anyway. Next slide. So the Quality Payment Program has two payment tracks, which is the APMs, Advanced Alternative Payment Models, and the MIPS, which is the Merit-Based Incentive Payment System. With the APMs, it's an innovative payment model, and it rewards providers for delivering high quality and cost-efficient care. Most providers who participate in APMs will also be subject to MIPS, but will receive favorable scoring and correspondingly higher reimbursement rates. With the merit-based incentive payment system, it's performance-based, measured and paid based on 4 aspects, which is quality, resource use, clinical practice improvement, and meaningful use of certified electronic health record technology. This is reviewed annually. The guidelines will determine whether providers' compensation for Medicare Part B reimbursements is adjusted up for superior performance or down for performance that falls short of the established mean. Next slide. So who is part of the Quality Payment Program? Any advanced APM, or if you bill Medicare Part B more than $30,000 per year and provide care for more than 100 Medicare patients. Physicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists. It's important to note that the first payment adjustment based on performance go into effect on January 1st, 2019. Next slide. As you can see, not only are there mounds of information to learn as a medical group practice manager, there are many things you can begin to do and explore now. The majority of physician offices used to be privately owned, but there has been a dramatic shift in the last 10 to 15 years. Now, it is estimated that 70% of physicians are employed by hospitals and 30% are in private practice. The skills for medical group management can be used in both private and hospital-based practices. In a hospital-based practice, you may have a more specific job role, such as human resources or a compliance manager, but there's always room in the industry for a medical practice manager. Thank you for watching and good luck with your studying this week.